Okay, so let's talk about feet. Footsies, dogs, trotters, pieds, if you're French, or whatever you want to call them, feet are an important part of diabetic care. So today we're going to talk specifically about diabetic feet. Whoa, whoa, whoa. What do you mean by diabetic feet? I know about diabetes, but what does that have to do with feet? Well, let me tell you. Let's start off with a little information about diabetes. Currently, there are 3 million Canadians living with diabetes. For people living with diabetes, ulcerations and amputations are one of the most feared complications and a huge cause of morbidity and mortality. Around 15 to 25% of Canadians living with diabetes will develop a foot ulcer within their lifetime, and Canadians living with diabetes are 20 to 25 times more likely to lose a leg compared to the general population. Now, a lot of work has actually been done nationally and internationally to reduce the risk of diabetes related complications. But studies in Ontario have shown that while rates of other diabetes complications, such as myocardial infarction, stroke, and renal disease, have decreased over the last decade, rates of amputation may actually be on the rise. Whoa, I had no idea this was even an issue. Now I'm concerned. My Uncle Teddy has diabetes. But why is this such a big problem? Do we just not know how to prevent amputations? Those are all great questions, and we actually know a lot about preventing amputations. In fact, nearly 80% of amputations are preventable. In Canada, practice guidelines on foot screening have been published by Women's Canada, Diabetes Canada, the Registered Nurses Association of Ontario, and the International Working Group of the Diabetic Foot. However, despite the availability of these guidelines, Canada has largely failed to implement them into practice. This has resulted in huge societal and economical costs for patients, including lost wages, job loss, lengthy hospital and rehabilitation stays, and increased need for home and social services. I don't get it. If we have all these guidelines, what's stopping people from getting care? Why aren't we using them? Well, let's take a look. When we zoom out and look at this issue, we see that 85% of amputations are actually preceded by a foot ulcer. This means that in order to reduce the risk of amputation, we need to first reduce the risk of ulceration, which means starting off with good diabetic care. Today, Canadians living with diabetes continue to face barriers when accessing care due to a variety of system, social, and geographical factors. In 2023, Diabetes Canada actually put forward a position statement on amputation prevention. But this is a lot. So, we're going to summarize this into 5 key points. Access to medication and medical devices. Let's start off with 2 key strategies for preventing foot ulcers: medications and medical devices. First, medications are a key strategy for maintaining good glycemic control or blood glucose control. Second, for those impacted by diabetic foot complications, offloading devices and prosthetic are key to preventing further complications and helping to improve outcomes. However, Canadians actually face a large affordability issue when it comes to accessing medications and medical devices. Provincial out of pocket costs can vary wildly and can be as low as $76 to over $18,000 a year. In fact, the majority of Canadians living with diabetes will allocate more than 3% of their income to prescribed medications and medical devices. Medications, I understand, but offloading devices and prosthetics? How expensive can those foam boots really be? And also, I thought prosthetics were covered by the government. Yes, those are technically true, but costs stack up quickly. Offloading devices, for example, cost between $1,400 and $2,000, which is unaffordable to most Canadians, leading to decreased usage. When it comes to prosthetics, only 8 Canadian provinces have dedicated policies around coverage, and most provinces require Canadians to at least cover 25% of the cost. When prosthetics have an estimated 5-year cost of between $85,000 and over $200,000, this is a huge ask. So the reality is that most Canadians living with diabetes often have difficulty affording these devices. Number 2, foot care and education. Good foot screening, care, and education are key to preventing amputation. At minimum, healthcare providers should be providing yearly screening for patients with diabetes in order to assess the risk of complications. But is this actually happening? Nope. Well, you're not alone, Teddy. Reports have found that over half of Canadians living with diabetes have not had their foot screened by a healthcare provider within the last 12 months, and over 1/3 have not had their foot screened at all. About 40% of patients report to not being able to identify risk factors of diabetic foot complications, and 45.5% of amputees have reported to never having received foot care education. Compared to other nations like the UK and Scotland, where screening rates are as high as 80%, Canada is falling behind. Well, How do I find someone to look at Uncle Teddy's feet? Another great question, and that brings us to our next point, access to dedicated interdisciplinary teams. When foot complications occur, guidelines recommend referral to dedicated interdisciplinary teams. These teams should include nurses, vascular surgeons, primary care physicians, podiatrists, chiropodists, occupational therapists, and physical therapists. However, these teams do not exist in most areas of the country, and most acute care facilities lack key providers. Patients with other serious illnesses, such as cancer, often benefit from having clear regional pathways of care. However, for limb loss due to diabetes, only 3 Canadian provinces have dedicated referral pathways. In fact, 80% of Canadians rely on informal care pathways that may fail, particularly for those from marginalized communities or who already have medically complex needs. This is even more true for Canadians living in remote and Indigenous communities. Number 4, outreach to remote and Indigenous communities. When we are looking at access to diabetic foot care, it becomes clear that Canadians living in remote and Indigenous communities are disproportionately impacted. Statistics Canada has found that residents living in remote communities are 50% more likely to experience diabetes-related hospitalizations. And Demestro et al. Found that people living with diabetes in Northern Ontario were more likely to get an amputation and less likely to have access to limb-saving revascularization procedures. Indigenous communities face unique challenges when accessing diabetic care related to racism, intergenerational trauma, and restricted access to resources. This has resulted in a diabetes rate 3 to 5 times that of the general population and an amputation rate 7 to 49 times provincial and national averages. Well, since this is such a big issue in so many communities, that means we must have a lot of research on it, right?
Number 5, current research gaps.
Actually, we don't, and much of the existing literature points to this as a big problem. In comparison to other complications of diabetes like cardiac disease, diabetic foot complications have failed to attract the same level of research interest and funding. Research gaps cited by the literature include the economic impact of lower limb amputations, national incidence of diabetes related lower limb amputations, up to date health surveys looking at gaps in diabetic care, and auditing of the quality of diabetic foot screening across Canada. It's outrageous! Who do I need to talk to about this? Well, there are actually quite a few people that we need to talk to. First, people living with diabetes and their caregivers, as they are the target population to benefit. Next, leaders in remote and Indigenous communities, in order to gain a better understanding of how these communities are disproportionately impacted. Next, professional organizations, including nurses and physicians associations, as they will be needed to explore potential barriers to implementation of guidelines and review professional standards and competencies in diabetic foot care and limb preservation. Next, healthcare leaders in primary, acute, and long term care in order to review current organizational programs and care pathways and address current gaps in care and potential sources of funding for research development. And finally, federal and provincial governments, as they will be needed to address gaps in public funding to reduce out of pocket costs, create clear clinical pathways between healthcare organizations, and conduct nationwide research. Okay, but how do we get all these people to change? I'm glad you asked. What we need is a national strategy for limb preservation and clear diabetic foot care pathways. Canada can actually learn a lot by looking at provinces like Alberta and countries like the UK who have developed successful limb preservation and foot screening programs. Now, we are a little short on time here because Uncle Teddy sounds like he needs some lunch. So, we won't look at everything, but in order to get these programs off the ground, we need to look at 3 levels: micro, meso, and macro. First, the micro level. At the micro or individual level, there are 2 key groups: patients and healthcare providers. Patients have a role in being proactive about care by engaging providers and asking them to discuss risk of developing ulcers or complications, and performing daily foot exams by looking at areas between toes and the bottom of a foot for wounds or redness and examining nails for damage or color changes. Healthcare providers have a role in providing diabetic foot screening using evidence based tools, referring patients to appropriate services according to risk, and helping patients to navigate health systems, developing interprofessional plans of care that include patient and caregiver goals, facilitating client centered learning on how to provide adequate foot care, and providing feedback to organizations about potential barriers for implementing and taking an active role in policy development. Number 2, meso. At the meso or organizational level, healthcare organizations have a role in making a commitment to follow the calls to action in the Truth and Reconciliation Act to reduce barriers of care for Indigenous communities, conducting assessments of organizational readiness and barriers to implementing best practice guidelines, developing policies and designated resources to the development of interprofessional foot care pathways, providing education and training for staff on evidence based diabetic foot screening, understanding mapping and formalizing clinical pathways in their community, curating resources and toolkits for providers and patients, and developing forms and documentation systems for the assessment and management of diabetic foot complications. Number 3, macro. At the macro level, provincial and federal governments have a role in ensuring that Indigenous communities have adequate access to care and addressing their unique barriers and health needs, developing and implementing national and provincial foot screening programs and guidelines for healthcare organizations, ensuring all Canadians have equitable access to limb-saving revascularization procedures and diabetes care across the spectrum, adopting a nationwide approach to reduce out-of-pocket costs for medications and medical devices, set out guidelines for appropriate coding and documentation to ensure accurate reporting, set out standards for measuring and tracking amputations and wound care data across the continuum of care, and funding and supporting research that addresses current knowledge gaps. I mean, this all sounds great, but how do we make sure all these strategies are actually effective? This is the final step to ensuring ongoing change and improvement. And to do that, we need to implement evaluation strategies by looking again at the micro, meso, and macro levels. At the micro level, healthcare professionals need to continuously self evaluate whether or not they are implementing best practice guidelines into care, and engage in self assessment of knowledge of the management of diabetic foot complications. At the meso level, organizations need to engage patient, families, and community stakeholders to ensure that current care pathways and practices are meeting needs, auditing utilization of developed forms, tools, and referral programs for foot care, and auditing hot foot lines, wound clinics, follow up care, and screening programs by collecting data on regional and organizational rates of amputation, hospital length of stay, wound healing time, number of ulcer-free days, functional activity level, rates of hospitalization, and risk stratification. And finally, at the macro level, governments need to set clear timelines for the development and adoption of nationwide approaches to reduce out of pocket costs for people living with diabetes. For example, universal pharmacare and complete provincial coverage of offloading devices and prosthetics. Set timelines for organizations to meet guidelines for appropriate coding and documentation. Measure and track amputations and wound care data across the continuum of care, collect data of gaps in diabetes care and identification of high-risk communities, and conduct ongoing auditing to ensure that organizations include best practice guidelines and models of care adapted to their unique regional environments. Whoa, that's a lot. That's right, Teddy. While this is a complex issue, by working together, we can save feet and limbs across the country. I hope you found this video informative. A special thank you to Teddy, my mom, and the cardiac and vascular surgery team at St. Michael's Hospital. If you liked this video or found it informative, give it a like. Or if you're a healthcare provider, share it with one of your colleagues. And if you'd like to learn more or find out about some of the resources I used, all of them can be found in the description below. Till next time, take your shoes off and check those feet.